So here I bring greetings from my institute once again to all of you for the happy Diwali. And I'll cover cerebral physiology, cerebral perfusion pressure, and the relevance of ICP in cerebral perfusion, and some history about the evolution of ICP monitoring and techniques of ICP monitoring, and where we stand now and what is the evidence. Intracranial pressure is the most important determinant for the outcome of neurologically injured patient, be it trauma, be it tumor, be it vascular injury or CNS infection. Several studies have shown that ICP monitoring helps in the management of intracranial hypertension and improves the outcome. Brain is a complex and unique organ. It comprises of only the 2% of body weight, but enjoys the lion's share of basal cardiac output, 15% of cardiac output, and has the highest metabolism in the body, mostly oxidative, and that of glucose, the main nutrient, and consumes 20% of the basal oxygen. CMRO2 is equal to 50 ml per minute, and the CMR glucose is 4 to 5 milligram per 100 gram of brain tissue per minute. Glucose is not only the energy substrate, but also is a precursor of the neurotransmitters. And virtually, the brain has no storage of glucose. So totally it depends upon the cerebral perfusion to get glucose and oxygen. Loss of consciousness ensures within seconds of cerebral ischemia. Disruption of critical decrease in the cerebral perfusion only for 3 to 5 minutes may result in permanent brain damage or even death. But autoregulation is there to protect the brain. It has its own autoregulation, which is a physiological process and mainly myogenic. And there occurs the cerebral precapillary vessels. They adjust their caliber against the cerebrovascular resistance and maintain the cerebral blood flow. When there is hypertension, the TMP, the MAP rises, and the TMP is also rises, the transmural pressure, and there is vasoconstriction, and the reverse occurs when there is decrease in the MAP, there is vasodilatation. And the process is instantaneous within 1 to 10 seconds. Suddenly it will happen. And maintained by, it is mediated by EDRF and nitric oxide. The autoregulation is maintained between the pressure threshold of 50 to 150 millimeter of mercury. Above and below this level, the CBF is pressure dependent. This graph shows that the factors that are responsible for vasoconstriction, vasodilatation, and the affect the CBF and the cerebral blood volume. Apart from autoregulation, the PaCO2 is very, very important for maintaining the cerebral blood flow. It regulates cerebral blood flow. 1 millimeter mercury change in the PaCO2 will change the blood flow by 2%. And similarly, PaO2, pH, temperature, rheology, these all factors, they also change the CBF. They affect the CBF. This curve is the flow metabolism coupling form is a dynamic occurrence where CBF changes in relation to CMRO2. When there is increased metabolism, the CMRO2 increases, and also the CBS increases too. Now coming to cerebral perfusion pressure. Cerebral perfusion pressure. Any perfusion pressure is the difference of arterial and venous pressure. Any organ will survive and will be functional only by the perfusion. Here in brain, so it is the perfusion pressure, and for all organs it is the mean arterial pressure minus the venous pressure. And brain is no exception. But here in brain, the cerebral perfusion is affected by another pressure, that is the ICP. because the skull is a rigid box. It has 3 volume compartments: brain, CSF, and blood. Brain 80%, CSF 10%, and blood 10%. And the volume is always constant. The pressure volume relationship is maintained by a dynamic equilibrium between the 3 compartments. And any change in the volume will be reflected on ICP. But what occurs? We must go to the Monroe-Kelly doctrine. What they say that increase in the volume of one compartment is compensated by shifting or compression of the other one or the other 2, or else the ICP will rise. So this Alexander Monroe, he and his disciple George Kelly, they gave this concept in 1783. So these are the genesis of ICP. I'm not going into that because it's a clumsy slide. So I'll show you what are the historical landmarks. 1783, Alexander Monroe, he first mentioned about ICP. 1828, establishment of the Monroe-Kelly doctrine. 1916, first measurement of CSF pressure by Hans Kuchenstedt. 1926, Harvey Cushing, the father of neurosurgery, he showed the linkage of CSF and ICP. In 1951, first ICP measurement is by J. Guillemey. And in 1973, there is subarachnoid screw and bolt. They were invented by Barris, Baker, and Young. So from here, we can go for the measurement. In 1982, Transcranial Doppler came into picture. And 84, the Kosman bolt by Carl Swan and Eric Kosman. So this is the evolution. Now we have also many types of parenchymal monitors. By the turn of 20th century, it was known that the increased ICP following head injury determines the outcome. And Jubilee reiterated the need for trephines in head injured patients to release ICP. In 1938, Jefferson described the syndrome of uncal herniation as a consequence of intractable intracranial hypertension. With introduction of coma scoring, CT scan, ICP monitoring, better appreciation of the intracranial compliance, and CSF dynamics, management guidelines for increased ICP have been evolved. So what is ICP? It refers to the pressure inside the cranial cavity and is reflected by the CSF pressure. The normal ICP in adult at rest in lying down supine position, 5 to 15 millimeter of mercury. The variation in ICP is influenced by CSF dynamics, cerebral circulation, and intracranial abnormalities. Multiple studies have confirmed that sustained increase in the ICP more than 20 millimeter of mercury worsens outcome and must be treated. This is the famous pressure volume curve. All of you know about it. And the resistance is equal to the ICP change by the volume change. The pressure volume index, which is the volume that causes 10-fold increase in ICP. This is very important. And the pressure in volume index is 25 to 30 mil. About this amount, if you inject in one of the normal patient, normal individual, there will not be any increase in the ICP. But if the pressure volume index is more than 30, or you add more than that, then there will be increase in the intracranial pressure. So the compensation will be exhausted. This is the genu of the curve, and here the volume compensation is reaching to exhaustion. And after this, any addition in the volume will increase the pressure sharply, and there will be reduction in the CPP, and there might be the herniation, brain herniation. So it will be very catastrophic. But there are compensation phases. That phase 1 is the CSF compensation. The CSF is forced to the spinal subarachnoid space. This is the first compensation. Then when again the volume is rising, then the pressure is rising. So to compensate that, the second phase is a compression of the venous sinuses along with the CSF shift. And the phase 3, here all the venous sinuses are collapsed and the shift of entire volume of CSF to the spinal subarachnoid space is done. At this stage, slightest addition in the volume, slightest increase in the volume will cause rapid increase in the intracranial pressure and the patient may herniate. So what are the causes of intracranial hypertension? Intracranial hemorrhage by TBI, rupture aneurysm, AV malformation, other vascular abnormalities, and CNS diseases, starting from neoplasm, ischemic infarcts, vasculitis, encephalitis, meningitis, pseudomotor cerebri, and idiopathic intracranial hypertension. This picture shows this is a PG bleed. BG bleed, the basal ganglia bleed in a stroke patient, hemorrhagic stroke, hydrocephalus, brain tumor with very good amount of shift, and this is in idiopathic intracranial hypertension with papilledema, and this is a CT scan of the post-traumatic hemorrhage and meningo. This is the MRI of meningoencephalitis. You can see here, and this is acute infarct with compression of one of the ventricles there, and this is a perfusion study, MR perfusion. So now, what is the clinical importance of intracranial hypertension? Why we are very much worried about the intracranial pressure and intracranial hypertension? Because the CPP, we are much concerned about the cerebral perfusion. So cerebral perfusion pressure is the mean arterial pressure minus the intracranial pressure, as I have said. And also isolated increase in the intracranial pressure is independent of mean arterial pressure and may cause hypoperfusion and ischemia and neuronal injury and leading to neuronal death. Normal cerebral perfusion pressure should be maintained at 70 to 80 millimeter mercury. If it is less than 50 millimeter mercury, ischemic cellular damage will occur. And uncontrolled intracranial hypertension may cause brain swelling, brain herniation through transtentorial or transforamen magnum, and brainstem compression, and mortality is as high as 58%. This graph shows the relationship of the CPP and ICP, and when the CPP, the ICP increases to a critical level, the CPP falls below 50 millimeter of mercury. So there will be ischemia. The pathophysiology of increased ICP, as we know that it will reduce the CPP, cerebral ischemia, release of biochemical markers like calcium, excitatory amino acids, free radicals, and ionic fluxes. Therefore, potassium and magnesium, inflammatory mediators, cytokines, they will be released and they will cause neuronal injury. It also causes disruption of there is in increased ICP, there is disruption of the blood-brain barrier, and which may lead to vasogenic edema. And this release of the excitatory amino acids and the biomarkers will cause failure of the ion pump, and there will be leakage of calcium and potassium and cytotoxic edema. Both this vasogenic and cytotoxic edema will cause the brain swelling, increase ICP, reduce CPP and ischemia, and the vicious cycle will go on. So these are the stages of intracranial hypertension. In the first stage, there is minimal increase in the ICP and the compensatory mechanism is there. As the compensatory mechanism is there, so minimal increase in the ICP. It will not affect the health. But in case, if the compensatory mechanism exhausts and the ICP goes on rising, then any addition in volume will cause drastic increase in the ICP. आगे चले जाच्छे So as ICP approaches MAP, as the ICP is increasing, the ICP will approach to MAP. So when it approaches MAP, the body responds to increase CPP by vascular dilatation. So there will be maximal vasodilatation and the cerebral blood volume will increase and there will be increase in the ICP and the vicious cycle will go on. And this will cause cerebral ischemia and further infarction. So now, what are the indications of ICP monitoring? Number one is the traumatic brain injury, and many work has been done in this traumatic brain injury and ICP monitoring. Subarachnoid hemorrhage, intracerebral hemorrhage, hydrocephalus, malignant infarction, post-craniotomy cerebral edema with a brain shift, and CNS infection, and also non-CNS hepatic encephalopathy. There is level 2B recommendation by the Brain Trauma Foundation that ICP monitoring reduce in-hospital and 2 weeks post-injury mortality. So ICP monitoring should be done. That is a recommendation by BTF. And also BTF in severe traumatic brain injury has a level 2 recommendation that if the GCS is 3 to 8 or less than 8, and there is abnormal CT findings, go for ICP monitoring. And if the GCS is less than 8 with normal CT, but two or more of the following are present, like age more than 40 years, unilateral or bilateral posturing, systolic BP less than 90 millimeter mercury, go for ICP monitoring. There is also level 3 recommendation by BTF that if the initial CT is normal or with minor change, but later the neurological worsening occurs, so go for monitoring. And if there is evidence of brain swelling in the CT, compressed basal systems, go for ICP monitoring. If there is large bifrontal contusion, go for ICP monitoring. When sedation is not justified in patients having flail chest, lung contusion, having respiratory failure, you cannot give sedation. In those cases, you have to monitor the intracranial pressure. Neurological examination is not reliable in many patients having the maxillofacial trauma or spinal cord injury. In those cases, one should monitor the intracranial pressure if required. Post-craniotomy brain edema and a midline shift of more than 5 millimeter, one should go for monitoring. Now, what are the contraindications? Contraindications are concurrent use of anticoagulants, bleeding disorders, scalp infection, brain abscess. One should avoid ICP monitoring in these cases. Now, coming to the ICP waveforms and how you recognize them and what is how you analyze them. This is a normal ICP waveform. There are 3 peaks occur with each cardiac cycle and correlates with the arterial pressure waveform. The P1 is the arterial pulsation, P2 denotes the intracranial compliance, and P3 the diacritic pulse. So diacritic. So in normal case, the P1 should be more than P2, and in height, in height it will be more than P2, and P2 is greater than the P3. But in cases of if abnormal, what occurs in abnormal thing? In abnormal or poor intracranial compliance, there is increased amplitude of P2, and P2 becomes greater than P1, and there is rounding of the waveform. This indicates poor compliance, intracranial compliance, and raised intracranial tension. And these are the Lundberg waves. We have also Lundberg waves also. The Lundberg has described 3 types of waves, A, B, and C waves. The A waves are the pathological waves. They are the plateau waves, and they have intermittent sharp peaks, and the duration is 5 to 10 minutes. Amplitude is 50 to 100 millimeter mercury, and they are pathological. And the Lundberg's B wave is rhythmic oscillations, sharply peaked, occurring every 1 to 2 minutes. This reflects the vasometer changes and an association with an unstable ICP. So one should, when you get B wave, you should be very cautious. And A wave, you go for drastic management. And Lundberg C wave is a trouble-hearing mere fluctuations in arterial pressure by oscillations of the baroreceptors and chemoreceptor reflex control system, and it can be seen in the healthy individuals. So it is so not specific. This is the intracranial compliance curve. Here you can see that for the starting point, there is a compensation phase and high compliance. Here, if you just add some volume, there will be room, and there will not be any increase in the intracranial pressure. But as the volume increases, the compensatory reserve gradually depleted, and the decreasing compliance will be there. And there will be minimal, in the third stage, you can see that the compliance is minimal and increased risk of cerebral ischemia and herniation here, if you add a bit of volume. And in the fourth stage, there is collapse of the cerebral microvasculature, and there will be no change in the cerebral microvasculature in changes with the cerebral blood flow. No vasoconstriction or vasodilatation. Maximum vasodilatation will be there, and there will be collapse of the autoregulation. Now, what is the index of pressure volume compensatory reserve? The R is the RAP. RAP is an accurate measure of the intracranial compliance. And it is R is the coefficient, A is the pulsation amplitude, and P is the mean ICP. You can see in this graph, and it varies between -1 to +1. RAP 0 is a compensatory reserve phase, and here the good compensation is there, so there will be no increase in the ICP if you add something. But in second stage, when the RAP is 1, it is poor compensatory reserve. Here, any addition, any light addition will cause increased pressure. And in the third phase, the RAP is less than 1, and the cerebrovascular reactivity is deranged, and there is autoregulation failure. And there will be again brain edema, and the vascular reactivity is lost. The pressure reactivity index is very important. It is, if it is positive, it indicates impaired autoregulation. It is an indication of the autoregulation. And if it is negative, it reflects the normal autoregulation. You can see here the PRX, how the CPP is changing with the PRX. If it is positive, then it is indicative of impaired autoregulation, and there is CPP is low. Now coming to the methods of ICP monitoring, The clinical examination is always important. A patient will complain of headache, nausea, vomiting, and there is double vision, present with double vision, and the pupillary asymmetry might be there. And on examination, you will find a fundoscopy, you see papilledema. And hemodynamic changes might be there. It is the last stage, the Cushing's triad, as we know, the hypertension, bradycardia, and bradypnea will be the Cushing triad. And here it is, the patient is now herniating. And in non-invasive methods is imaging, CT, MRI. You can detect any intracranial mass, bleed, hydrocephalus, edema. These are the non-invasive monitoring of the ICP. Then the next one is the transcranial Doppler, which has changed everywhere. It is ultrasonography has changed the picture of everything. So not here also transcranial Doppler. You can assess the cerebral vascular vascular either spasm or it is normal. So this is a non-invasive and indirect measurement of ICP. But the advantage is non-invasive, transportable, and disadvantage is the margin error is 10 to 15 millimeter of mercury. And it is difficult in 10 to 15% of cases, as there might be absence of adequate bone window. So you cannot monitor. In this respect, we need to have the pulsatility index. It is the peak systolic minus the end diastolic velocity by mean velocity. So the pulsatility index, if it is increased, then it is the vascular, there is vasospasm. Mainly it is indicated in the vascular lesions like cerebral intracranial aneurysms, and by after this coiling or after subarachnoid hemorrhage or coiling or clipping of the aneurysm. We always monitor the transcranial Doppler to see the MCA velocity. And this is my friend, once upon was my student, now my colleague. So he's looking after a patient of aneurysm coiled, and the postoperative scan shows diffuse subarachnoid hemorrhage and cerebral edema, and transcranial Doppler showed MCA velocity is raised, and the pulsatility index is also raised, and so the ICP is raised. Next is tympanic membrane displacement. The CSF and perilymph, they communicate through cochlear aqueduct. An increase in ICP is transmitted to the footplate of stapes and changing its position. Inward displacement, that is negative peak pressure on audiogram, is suggestive of high ICP, and outward is normal or low ICP. But the limitations are accuracy is plus minus 15 millimeter mercury. Patency of cochlear aqueduct is compromised in elderly patients, and there will be erroneous results. The next one is optic nerve sheath diameter, and this is also transocular ultrasound. The space between optic nerve and its sheath continuous with the spinal with the subarachnoid space, and it is filled with CSF, and the pressure is equal to ICP. And any ICP rise will cause increase in the sheath diameter, and the blood flow through the central retinal vein is impeded, and that causes papilledema. Several large studies have validated ONSD as a screening method for increased ICP. And ONSD more than 5 millimeter corresponds to an ICP of 20 millimeter mercury or higher. The advantage is it's cheaper, non-invasive, takes only 5 minutes to see for the test, and limitations are lesions in the orbit, optic nerve tumor, or inflammation, Graves' disease, sarcoidosis, all these things will you cannot measure ONST. We in our institute, we routinely do ONST, and you can see my colleague doing a 28 years male with road traffic accident. CT scan shows depressed skull fracture, diffuse axonal injury, and acute extradural hematoma, raised ICP. The GCS is E1, M3, and VT, and the patient is having raised ICP, and it is monitored by ONST. Pupillometer, handheld infrared system which automatically tracks and analyzes pupil dynamics over a 3-second period. Very handy. Neurologic pupil index derived from size, percentage constriction, latency, and constriction and dilation velocity. The NPI less than 3 indicates raised ICP. I don't have any personal experience with this. Now, coming to invasive methods. Invasive methods are the gold standard, and starting from ventriculostomy and ventricular monitoring, intraventricular monitoring, you have intraparenchymal catheter, epidural, subdural bolts, subdural catheters, but they are all invasive. There are two types. One pressure transduction method type, and another is fluid coupled devices or non-fluid coupled devices. So the strain guns pressure transduction method, it can be external interventricular drains or internal with catheter tip microchip, and it may be fiber optic. The fluid coupled devices are connected to external strain guns, and non-fluid coupled devices, fiber optic or catheter tip microstrain guns. This is the interventricular devices, and it's the gold standard, can be recalibrated in vivo. Therapeutic uses are, you can always drain the CSF, that is, you can reduce the, treat the intracranial hypertension by draining the CSF, putting antibiotics into the ventricles, thrombolytics into the ventricles. And the disadvantage is two major disadvantages. One is infection and another is hemorrhage. And others are misplacement and obstruction of the catheter. This can also happen. Now, this Spiegelberg brain pressure monitor. It is a pneumatic sensor based and relatively low cost. Advantage is this: automatically zero drift correction in vivo, and a newer version having two double lumen catheter can drain the CSF also, and one is measures the intracranial compliance. So it's good, but I don't have any experience in using this. The limitations are ICP waveform analysis is very difficult in these cases because of the pneumatic device, I think so. Now the intraparenchymal devices, the fiber optic devices, that the Camino ICP monitor, and the strain gauge device, the Codman microsensor. They are now in use in many centers are using this. And the advantage of this is easily transported. Recordings are independent of patient positioning, low risk of infection and bleeding. But the disadvantage is cannot be recalibrated in vivo, and it can only measure local pressure, not global. Therapeutic CSF drainage is not possible and subject to drift when used for long periods. So these are the pictures of Camino and Codman, and now we have measured the ICP. Now management, if there is intracranial hypertension. There is a very clumsy slide, so I'll show you. Treatment algorithm for increased ICP are set by different organizations, Brain Trauma Foundation, American Association of Neurosurgeons, Neurocritical Care Society through ENLS, as it is intracranial hypertension is an emergency. Seattle consensus recommendation. The Seattle people, they have the consensus of recommendation. They are based on all these Brain Trauma Foundation recommendation, and they simplified for the use of or for practice of this algorithm. All of them, they recommended tiered system of management of intracranial hypertension. So I'll go to the Seattle consensus. It has came in 2019, and let us have a look here. In the first tier, there is the interventions are sedation and analgesia to give the patient comfort and reduce the metabolism, anti-seizure prophylaxis, seizure prevention, and mannitol hypertonic saline for edema treatment, and CSF drainage via external ventricular drain. If there is more, CSF is accumulated more. But the complications are hemorrhage and infection in EVD. Hypertonic saline may cause hypernatremia, mannitol hypotension and hyperosmolarity, and acute kidney injury. Anti-seizure prophylaxis drug may interact with other drugs, and there might be side effects of the drugs. And sedation analgesia can cause hypotension, and propofol induce the syndrome and PAP. If the patient is on sedation, then we have to make the patient may be on the ventilator, and it will end up with PAP. The second tier is mild hypocapnia. If there is hyperemia, to target is hyperemia, and you do mild hypocapnia. Neuromuscular paralysis to prevent coughing and all this. MAP changes to assess the autoregulation, and increase CPP. If the autoregulation, if the cerebral perfusion is low, you can increase the CPP by therapy. But there might be a risk of acute lung injury, vasogenic edema. And MAP changes with if the patient has autoregulation is not there, then there will be refractory intracranial hypertension. Neuromuscular paralysis may induce myopathy, prolonged duration of mechanical ventilation. And mild hypocapnia may induce ischemia. The third tier of Seattle consensus is mild hypothermia, 35 to 36 degrees centigrade, to reduce the metabolic suppression. As we know that 1 degree centigrade rise of body temperature may increase the cerebral blood flow by 7%. So mild hypothermia will reduce the metabolism. Then barbiturate coma for metabolic suppression, again, if it is refractory to mild hypothermia. Then decompressive craniectomy at the last resort, and if everything fails, to reduce, to make the room for the brain, you have to do decompressive craniectomy. The complications of decompressive craniectomy is bleeding, infection, subdural collection, and the syndrome of Trifine, survival with poor outcome. CSF bag the patient will have. And then barbiturate coma may induce hypotension, infection, myocardial ischemia, myocardial depression, and we have the ventricular ventilation associated pneumonia, because these patients have to be there on ventilator, and prolonged duration of mechanical ventilation. and mild hypothermia may cause infection. This is the ENLS guidelines. I will only discuss the tier 0. This is the measure to prevent herniation. Tier 0 assess the ABCs, minimize noxious stimuli, analgesia, sedation, target normothermia, head of the bed to be elevated to 30 degree, and neck should be midline. Isotonic or hypertonic saline should be solution should be given. Avoid and correct hyponatremia. Steroids in selected condition, not in trauma. So obtain a non-contrast CT. So this is the tier 0, which was not there in the Seattle group. ENLS guideline, I'm not going to the tier 2 and 3, they're all same. ANS guideline also the same, similar, first tier, second tier, and third tier. Now, how to approach? First, the patient comes and you approach to the ABCs, neurological examination. If the GCS is less than 8, go for the CT finding is consistent with raised ICP. And if the CT findings are consistent with raised ICP, because then you intubate the patient, or if resectable mass lesion is found in the CT, insertion of the ICP monitor and ventriculostomy should be done if the ventricles are dilated. Otherwise, if there is resectable mass, you resect the mass. And the patient should be head up 30 degree, head midline, sedation analgesia start, normocapnia should be there, VCO2 35 millimeter mercury, normovolumia, SpO2 more than 90%, and PaO2 more than 60 millimeter of mercury. And even then, if the ICP is more than 20, then CSF diversion, minimize the stimulation, prevent and treat seizure, prevent, treat fever, and if again the ICP is 20, more than 20, repeat a CT scan, start osmotherapy again, and mild hyperventilation, the 30 to 35 millimeter of mercury, and consider SgVO2 and PBTO to monitoring. ICP more than, in spite of that, ICP is more than 20, and so it will be stamped as refractory intracranial hypertension, and you go for hyperventilation on PSCO to less than 30 millimeter mercury. Moderate hypothermia, barbiturate therapy, decompressive craniectomy, EVD, or lumbar drain. So what are the baseline therapeutic targets? The systolic BP should be more than 100 millimeter mercury. You can use isotonic salines and vasopressors. CPP should be targeted to 70 millimeter of mercury, and SpO2 more than 95%, PSCO2 30 to 35 millimeter of mercury by controlled hyperventilation. Blood glucose should be 80 to 120 milligram per deciliter, and with regular insulin. Hematocrit more than 25%. Serum osmolality less than 320 millimole per liter. Serum electrolytes should be within normal limit. Core temperature should be 36 degree to 37 degrees centigrade, and we should target the ICP to 10 millimeter of mercury. Now coming to the goals and interventions. If your goal is cerebral volume reduction, evacuate the mass lesion if present, maintain euvolumia, hyperosmolar therapy plus minus loop diuretics. If you target to reduce the cerebral blood volume, maintain head position midline 30 degree, head up, maintain normocarbia, consider mild hyperventilation if refractory intracranial hypertension. And if you target, your goal is to reduce the CSF volume, go for ventriculostomy or external ventricular drainage, lumbar drain. And if your target or your goal is to reduce the metabolic rate, then normothermia, sedation analgesia, seizure management, seizure prophylaxis, and if the refractory intracranial hypertension, barbiturate therapy, mild to moderate hypothermia. Hello?
Please go ahead, man.
Can you hear me?
Yes, yes. No issues. Continue.
So the recommendations are by the Brain Trauma Foundation, ICP monitoring. It is a level 2 recommendation. All salvageable patients with severe traumatic brain injury, GCS 3 to 8 after resuscitation with abnormal CT, you must go for ICP monitoring. Level 3, level 2 or 3 evidence recommendation, severe traumatic brain injury, normal CT, but with 2 or more following, that is more than 40 years, unilateral, bilateral motor posturing, systolic BP less than 90 millimeter mercury. Now, the Brain Trauma Foundation also recommends hyperventilation as a level 2 recommendation. Prophylactic hyperventilation is not recommended. Level 3 recommendation is that the hyperventilation as a temporary measure to reduce an acute increase in ICP can be taken up, but it should be avoided during the first 24 hours of the head injury because it is the hypoperfusion stage and the CBF is critically reduced at this stage. SjVO2 and PVR2 monitoring should be along with intracranial pressure monitoring will be used when you institute hyperventilation. My time is up, no?
Thank you,
Okay,
madam.
ma'am.
Huh?
Thank you, ma'am.
Okay.
Thank you, madam, for the wonderful exhaustive lecture. I may put it as one of the exhaustive lectures
So
on the intracranial pressure.
I'll just end up. I'll just
Yeah,
end
yeah. Okay, if you want to, yeah, go ahead. If you want to end up that way, yeah,
only I'll just some recommendation.
yeah. Okay, okay.
Now, is ICP monitoring is beneficial? There is a trial, multicentric control trial, best trip trial. They reveal that for patients with severe traumatic brain injury, but they have shown that if it is with intraparenchymal ICP monitor use, and they shown that it is not superior to care-based imaging. If you are having the clinical and imaging, it is not you can avoid the intraparenchymal devices. So that is their So to summarize, I'll say ICP monitoring is a robust brain monitoring modality which can be used to predict outcome and to guide the treatment. And interventricular catheters are the invasive, but the gold standard till date, and most reliable, accurate, and cost-effective. And they can also, we can have the therapeutic CSF drainage to treat the patient's intracranial hypertension. Multimodal monitoring technique with PbO2 and cerebral microdialysis along with ICP, the outcome prediction and decision is better. But we'll also think that the future ICP monitoring, we hope it should be ideally non-invasive and able to give continuous reading and can be used as an outpatient setting. So thank you very much for all of your, this is my ICU team, and thank you very much all of you for giving me this patient hearing.
Thank you, Dr. Bibhukalyani, for the wonderful lecture. As I said slightly earlier, probably one of the exhaustive lectures on the intracranial pressure monitoring, and you discussed it threadbare. I don't think anybody has any particular doubts remaining with them on the intracranial pressure monitoring and management.
I'm there for any questions. If any...
And I went look at the chat box.
Okay.
Well, is there any question in the chat box, Sanish? Sanish, are you there with me?
Yes, yes. And no, sir.
No. Okay, I have one question, madam.
Yes.
Which I had been carrying along with me. In the brain dead patient, well, we maintain the brain dead for organ retrieval. We keep the pressure and the cardiac functional status optimal, as well as the nutrition also. Is there any reason or any role or anything beneficial if you monitor the ICP also in the brain dead patient waiting for organ retrieval?
Okay, that's a very nice question. But in a brain dead patient, the ventricles think, and if you go for the brain parenchyma, because of there is anoxia, there is already edema there. There is anoxia, and there will be accumulation of the chynes and all the mediators. So there will be edema. That brain will be swollen. Hypoxic brain damage is there. So there is no point of in measuring the ICP. Organ retrieval does not think that if it is a brain dead, so the EEG is flat. So ICP must be high in that case. So there is no scope of ICP monitoring, and which will we always go for EEG. We need to have there is electrical activities there or not. So that is.
Ma'am, there is one question in the chat from Dr. Vandana Mangal. How do we decide to give central neuraxial block to a patient who has a contusion or other intracranial lesions following head injury, but does not have signs and symptoms of raised ICP clinically and radiologically?
Actually, we all know that in case of raised intracranial tension, you should not go for lumbar puncture. And if it is at all required, so you should be very careful about that. You should be very careful. You see the intracranial pressure clinically, the patient, and see the imaging. If the patient is having hydrocephalus and there is connection with the spinal space, so you should not go there, because there will be herniation. If it is raised intracranial tension is more. Here now we have the intracranial tension, the lowest limit is the 22 millimeter mercury. If it is more than 22 millimeter mercury, then you should not go there. You can have it, monitor it by ONST. Optic nerve sheath diameter, you see whether the intracranial pressure is more.
Likewise, in endoscopic cranial surgery, is there any role for regular ICP measurement? Because we are not at all messing with the tissue. There is not that much of displacement of tissue going on in the endoscopic surgery.
In every case, you are not going to monitor the ICP, because there is debate there. There is controversy there. The ICP monitoring, whether it will be very helpful or it is only the clinical monitoring along with the imaging is helpful, we do not know. You have non-invasive ones like your imaging. Now you have the flow imaging. You have the imaging facilities can tell you what is the blood flow type there, what is the tone.
Right.
So why to go for invasive monitoring?
Yeah, good. Thank you. Thank you for clarifying the doubts.
Thank you very much. Thank you very much.